So type 1,
Yeah.
no insulin. Autoimmune disorders, they destroy the beta cells that produce insulin. So with your type 1 diabetes, you will forever, they have to take insulin for a lifetime.
Yeah.
There's nothing there. Type 1, there's nothing that could help them except insulin because the body is not producing insulin at all. Okay, so that's that. Type 2, there are a few insulin receptors in type 2. There's a few. So how do we do that? The problem here is it's the person, it's you. So there's a few insulin receptors in type 2. And the problem, they said, is you, the patient, because it's because of the diet and the lifestyle. So with your in diabetes type 2, the problem is the patient and the lifestyle that the patient has. So there's a few insulin receptors that work. There's a few. So the few needs help. How do we get it better? So NCLEX questions mostly focus on type 2. So the first thing that you have to do with type 2 is diet and exercise. Those two. Did you see the pancreas in type 1? It is really sad. And then you have you in type 2. Look at the diet that you're having here. So remember type 1, there's no hope. There's nothing. Okay. So then your type 1, you have, there's none. Type 2, you have, if you have metabolic syndrome, we talked about metabolic syndrome in diabetes. It increases your risk for diabetes. What is metabolic syndrome? It's kind of low, it's kind of like the triad. You have hypertension, you have high blood sugar, you have obesity, and you have your lipids, total cholesterol. If you have any of these 3 or more criteria, you're definitely going to be a type 2. So hypertension means systolic pressure of over 130, blood sugar medications or high blood sugar when your blood sugar is over 100. Obesity, when they're defining it in terms that, which is good, in terms that will make us aware. I have never encountered, except in this book, that diabetes, like obesity, is described as a waist size of the size of the waist. So female 35 plus and male is 45 plus. Then you have your lipids, your cholesterol, the good and the, it's mostly the bad. So you want a lower LDL or HDL?
LDL.
LDL. So what is the good cholesterol? Is it LDL?
HDL.
HDL. So you want the higher HDL?
Yeah.
Right? Okay.
Yes.
So H, and then you have high, okay? And LDL means you want it, L is low. So further definition of it, diagnostics for diabetes, random blood sugar, 70 to 115. Hemoglobin A1C, under 5.7. Pre-diabetes, there's no random here, but the fasting blood sugar just keeps going up. However, your diabetics, random blood sugar is 200, And then hemoglobin A1C is 6.5 and higher. That's your diabetics. What are the signs and symptoms? For high sugar, right? Very high sugar, you're kind of like dehydrated because the sugar is so high in your system. It's kind of like the blood turns to mud. That's hyperglycemia. Signs and symptoms of high sugar. Remember in diabetes, 3 P's, right? Polyuria, polydipsia, and polyphagia. Okay, there you go. What is polyuria?
Increased urination.
Urine.
Dyspsia, polydipsia,
Excessive testing.
okay, and polyphagia.
Excessive hungry.
Hunger.
Okay. So these are the signs and symptoms of hyperglycemia. So you're noticing that even prior to your patients knowing that they're diabetics, there's frequent trips to the bathroom. And they're constantly thirsty. So we see that a lot before we say, let's check your hemoglobin A1C. Now, for your hypoglycemia, it's defined as blood sugar levels of 70 or less. And most common signs and symptoms are cold and
Clammy.
So you have to get them what? Candy or any form of
Juice.
sugar. Juice, anything. Soda, anything. So chocolate. Hypoglycemia is the more dangerous than hyper, because with that, if the brain does not get enough glucose, the brain will die. So hypoglycemia is something that we really need to watch out for because it's more alarming than hyperglycemia. So, causes. Something for you to think about, okay? If you ever have questions in any form, in your NCLEX exam, in your exit exams, this causes increased sugar. You have sepsis, infection, causes always your blood sugar to increase within the body. Sepsis, stress, if you're not taking your insulin, and steroid therapy. So if your patients require insulin and they are also placed on steroid therapy, or they're in the hospital because they have an infection, you know that the insulin doses will have to be increased, right? Because just the following conditions alone can cause high sugar. So remember, in any way, form, or anything, if they ask you sepsis, stress, and steroid therapy can cause your blood sugar to increase on its own, okay? So if you have patients that are already taking insulin and they're scheduled for surgery, or they're in the hospital because they have an infection, or they're started on steroid therapy, their insulin dosage will have to be increased even temporarily. So in any way, form, or anything, these questions will always come up for you. So sepsis, stress, steroids, and of course, if you're skipping your insulin, that can cause high sugars. So just remember those. For your low sugar, exercise, when you're exercising, right? You're using glucose, it lowers your blood sugar. And then again, alcohol does not really do justice to your blood sugars. Insulin peak times causes hypoglycemia. This is the most deadly. And we can get more into the peak times in a little bit. However, if your patients are having hypoglycemia, if they're awake, you ask them to eat juice, soda, crackers, anything that is high, that has a high sugar content. If they're asleep, what would you give them? Stab them with a
IV.
IV or a D50, dextrose 50. So just keep that at the back of your mind. So if they're unable to swallow, or they're in a coma, or they're asleep and their blood sugar drops, remember hypoglycemia is much more dangerous. You stab them with a D50. So it's dextrose 50 cc's. It comes in a syringe because it's 50 cc's only, and you could just stab it and give it to them.
Do most facilities have that available in the crash cart or in just on? Oh, okay.
In the crash carts.
Okay.
Yeah. So they have that. So now, health education. We know it's diet, right? Avoid simple sugars if you're diabetic, soda, candy, white bread, rice. Have a good fiber diet, brown. Everything has to be brown. And then white bread, really. And rice is not good for you. So again, they said diet for type 2 and exercise. So just because we're talking about diabetes, how to take care of the diabetic feet is one of those things that are really, 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 really very common in NCLEX also. So you want to, the diabetic feet is always a good breeding ground for bacteria. Bacteria loves it there. So you want to make sure the feet is clean, it's dry, avoid any injury, no flip-flops, no high heels, no, remember, only the podiatrist can cut the nails. It has to be straight, not curved, not angled, right? So no hot baths. Sometimes you can't feel the water. So the nails have to be cut straight. Now, NCLEX keywords. Daily inspection of the feet and not weekly, okay? So daily, not weekly. That's why diabetic patients, you have to ask them to remove their socks prior to bed. So daily inspection of the feet. Shoes has to fit properly. No sandals, no flip-flops, no high heels. Why? Because you're trying to prevent injury. Cotton socks that are soft, not nylon. And then nails have to be trimmed, cut straight, not curved angles. So no callus remover, no heavy powder, no rubbing of the feet very hard, no hot baths or hot pads. No hot pads because you're gonna get burnt. Warm is okay, but not hot, okay? So complications, of course, diabetes, kidneys, right? Right away. A creatinine level of how much?
1.3.
Over 1.3.
Creatinine
1.3.
level over 1.3. Eyes, retinopathy, right? Diabetics can go blind. Heart, hypertension, atherosclerosis, brain, you could have a stroke, and nerves is neuropathy or loss of feeling also. Now, insulin. And insulin types. This is something that you have to remember, because if you see, most of your questions are coming from, it's all about insulin and peak times. So the terms that we have to know, when we say onset, onset is when the insulin first begins to act in the body. That's onset. Peak is when the insulin is exerting maximum action. This is the time that is very crucial, because this is the time when hypoglycemia occurs. So peak is when the insulin is exerting its maximum action. Onset is when it begins. Peak is when it is at its maximum strength. And then duration is just the length of time the insulin remains in effect. But just so you know, peak time is when it's exerting its maximum strength. Now, you have different types of insulin. You have long acting. Your long acting are your Detamir, your Glar, I can't say this.
Glargine.
Glargine,
Glargine.
your Levemir. These are your long-acting insulin. Detamir, Glargine, Levemir, your mirs. There is no peak for these types of insulin. So it's long-acting. There is no peak. There is no risk for hypoglycemia, right? Because it's long-term. So no cause for anything, no cause for worry. Detamir, Glargine, and Levemir, long-acting insulins, they do not have any peak. So it's kind of like a slow, steady release of insulin. It does not peak. So slow, steady release of insulin in the body. It's long-term. You do not have to worry about hypoglycemia because there is no peak. Also, these types of insulin, your long-acting insulin, they cannot be mixed with any other type of insulin. So if you have to give Detamir and you have to give regular insulin, it has to be drawn in 2 different syringes. Long-acting insulins cannot be mixed with any other form of insulin, okay? Long-acting, they do not peak. You do not have to worry about them. So then the second type of insulin are your NPH. They're the intermediate. They peak from 4 to 12 hours is their peak. So if you're giving the medication at 8 a.m., what times do you have to worry about that your patient could go into hypoglycemia?
Starting from 12.
Mhm.
If 12 until
12 hours. 12,
12 to 12.
12 to 12 to
12 to 12, right?
12.
12 until
12.
4 to 12 hours. So it's 4 to 12 to 8, right? So 12 p.m. to 8 p.m. So anywhere within the time frame, your patient could go into hypoglycemia. So any choices that they have there for you that is within the time frame is your answer, not prior, not after. Within the time frame of 4 to 12 hours is when NPH peaks. So something that you have to know, okay? Another thing about NPH is you can never give NPH IV or mix it in the IV bag or IV push. You cannot give NPH insulin through the IV in any way or form, not through the IV. It has to be given sub-Q. It's mostly given 2 times a day, 8 a.m. maybe, and 6 p.m. So, and then it can be mixed. Remember, NPH is cloudy, right? NPH is cloudy. You can mix NPH with regular insulin, right? What would you draw first? When you
Regular.
regular. So you have to draw clear and then cloudy. Clear is regular is clear, right? NPH is cloudy. You always have, when you're mixing insulins, you always have to draw clear first and then cloudy. So clear to cloudy, okay? What about if we have to mix Levemir and regular insulin? What do we have to draw first?
Separate.
Regular.
Separate. Separate, because Levemir, long-acting insulins, cannot be mixed with any other form. So, NPH, 4 to 12 hours is peak. Regular insulin. This is the only type of insulin that can be given IV push. Regular insulin can be given IV. The only type of insulin that you can give IV. The peak time for them is 2 to 4 hours. So when you're looking at your choices, the closest to 2 and 4 hours is the one that needs to be chosen. So no other type of insulin can be given IV except your regular insulin. Then you have your rapid insulins, Aspart, Lispro, and Glulicin. So Lispro is more common, I think, out of all of them. These are rapid acting insulin, faster than even your regular insulin. So we have to remember that this is the most deadly. Peak is 30 to 90 minutes. Onset is 15 minutes. Onset is the time that the insulin, how did we define onset? It's when insulin first begins to act in the body. Onset. Onset for your rapid acting is 15 minutes. So when do you give this type of insulin? For your diabetic ketoacidosis, right? That's the worst forms, and you could give rapid acting insulin there. You only can give this insulin if indicated, if the patient is already eating, okay, during meals, not prior, but during meals. The only reason is it's very fast. Rapid onset is within 15 minutes.
What if they have like a snack or like a granola bar with them?
It should be a full meal, depending on the amount
Okay.
of insulin that you're giving.
Because I remember I had a patient, well, I don't know if it was their preference, but he would get it like before each meal, like maybe like 15 minutes before each meal, but he would always have the granola bar to eat so that it doesn't get, so low before his meal gets there.
Yeah. Rapid acting insulins can only be get NPH. The peak time is still far, right? NPH is,
Yeah.
yeah. The regular insulin, 2 to 4
Oh,
hours. A granola ball can probably be fine with that. But your rapid acting, no.
definitely with the meal.
Definitely with the meal. Because in 15 minutes, they're
Gonna
gonna
go down.
start going hypo on you.
Okay.
And remember, that's the most dangerous thing is when they're going hypo.
Got it.
Yep. So, okay. So now we're going it. That's all about insulin. So the peak times are clear now. Okay. There's only 4 that you have to worry about, but you have to know exactly what those are. So as we said earlier, when you're a type 2 diabetic, diet and exercise first before you get started on oral medications. And one of those most common medications, oral medications used is metformin. Metformin synthesizes the liver to circulating insulin levels to reduce more glucose production. Something to do with that. So the liver produces more glucose also. So metformin just tends to stop that. There's a minimal chance of hypoglycemia with metformin. However, there is a possibility that you could have lactic acidosis. And that only occurs mostly if your patients have kidney failure. Very rare, but it does occur. So metformin can cause lactic acidosis, mostly for your patients with renal failure. No alcohol, absolutely. And if they have to go for any laboratory or diagnostics where it involves IV contrast, stop taking metformin 48 hours before. Because metformin is already killing your kidneys, plus the contrast for whatever test you're doing. So give your kidneys 48 hours to recover before you do. So stop metformin 48 hours before any scheduled diagnostic exam. That involves IV contrast. Other than that, this medication have to be taken as ordered and according to doctor's prescriptions. Your sulfonylureas, your
Sorry, Miss Stephanie, you said 24. You said 24 hours. Sorry.
48 hours.
48 hours.
48 hours. So you have your sulfonylureas, your glipizide, and your gliburides. So these are taken to lower blood glucose by stimulating the B cells of the pancreas to release insulin. This is what your glipizide does. You're very more prone to hypoglycemic effects here. So watch gliburide or glipizide. They're very sneaky. They're bad for the liver, the kidneys, and the elderly population. They're bad for your CHF patients. Avoid alcohol. It can cause sunburns, so use sunscreen. Gliburide. Gliburides and your glipizide, you are more prone for hypoglycemic effects with this medication than you would be with metformin. So you can see your patients cold and clammy with gliburide. There is this thing, I included this in here because I've seen a lot of Genovia. Recently, right? Isn't that new medications for diabetes? You've seen that on TV. They are called incretin mimetics. They're hormones. They help control blood glucose levels by enhancing insulin secretion and suppressing glucagon. So this is what Genovia is. Whatever it is, they also help control your blood sugar. The thing that you just have to remember with Genovia, it's not pregnancy safe, and it might increase serum digoxin levels. So if your patient is on DIG and Genovia, you have to watch digoxin levels for that, because I'm seeing a lot of questions about Genovia lately. Those are the new diabetic medications. So most diabetic medications are usually just insulin, metformin, glipizide, and or glyburide, and the new one is Genovia. So there's not a lot in there. Just have to know peaks for that. Now, something for you to remember, okay? Important points. They're saying that if there are peaks, it's peaks plus plates. This is what they're saying. So you'll remember peaks plus plates. Food during peak times to avoid hypoglycemia. So peaks plus plates. So P and P, always food during peak times. No matter what it is, food during peak times to prevent hypoglycemia. Again, they're telling you no peak, no mix. What insulin does not peak?
Long acting.
Long acting. The long actings, they do not peak. However, you cannot mix them also with other types of insulin. So they're saying no peak, no mix. Then you have IVP or IV piggyback only. What type of insulin is the only insulin that can be given IV?
Regular.
Regular insulin. And then they say, draw up what? Cloudy first?
Clear.
Clear before
Cloudy.
cloudy. And you have to remember when you're doing your insulin shots, you have to rotate
Location.
the sites. So site rotation. For your diabetic ketoacidosis, the only reason why it's here is just so we'll remember. Diabetic ketoacidosis is when the blood sugar shoots up, right? For whatever reason it is, your patient could be in a diabetic coma. So sometimes a question would ask you, would you still give insulin for your diabetic ketoacidotic patients, even if they're not eating? Would you still give your insulin?
Yes.
Yes, because the blood sugar is already very high. That's why they're in a coma, right? That's why they're in a diabetic coma, because the sugar is very high. So even if they're not eating, give them their insulin dose. Just if you ever come across a question like that. Then you have hypoglycemia is defined as blood sugar that is less than 70. So if they're awake, you ask them to eat, right? If they are sleeping or they are unconscious, you stab them with, or you give them a shot of the
D50.
D50. Hey, that was good. Now, I have given you drugs and antidote. So you will remember. This should not be here. Okay. What is the antidote for analgesics, your opioids?
Naloxone.
Naloxone.
What about heparin?
Protamine
Protamine
sulfate.
sulfate.
Coumadin?
Vitamin K.
Vitamin K.
Okay. What about digoxin?
Digigaban.
Digiband.
Digiband.
Beta blockers?
Glucagon.
Atropine.
Glucagon.
Glucagon. What about aspirin? Aspirin toxicity.
Sodium.
Vitamin K.
Sodium bicarbonate. What about therapeutic ranges? Digoxin. What is the therapeutic range?
0.5.
0.5 to 2.0.
What about dilantin?
20.
10 to
20?
20.
2, 20. What about vancomycin?
20 to 40.
20 to 40. So I will post the drugs and the therapeutic ranges for you, so you have that. I will also post the drugs and the antidote. There's not a lot, but you should know them because you will be asked them, right?
Mhm.
So we are done. Yay!
What is the second page? The drug therapeutic
The
range?
therapeutic, yes.
What is that significance when
Of
it says
So
the peak, the valley, and the peak and the through?
that has nothing to do with that. Is just specific to insulin. This one is if the blood level of your digoxin is higher than 2, it means
Mhm.
that you are going to have digoxin
Toxicity.
toxicity. Right? So this is the level where you need it to be. If your digoxin level is 2.5, it means that you are in
Toxicity.
digoxin, you are in toxicity.
Mhm.
If it's less than 0.5, it means that your digoxin level is too
Low.
low.
But I mean, for like the vancomycin, has its
Mhm.
peak and then true, and then the other one says,
Okay. So vancomycin at its peak and trough, you have to make sure that there is enough vancomycin level within the body. Peak is there's a certain amount of time for vancomycin also to peak. So you draw the blood level there at the peak and the trough. The trough means the duration. So when it's peak, you draw the blood level when it peaks. And if it's anywhere from 20 to 40, then you're within the therapeutic range. But if it is higher than that, it means you have a lot of vancomycin in the body, right? So they say you have to hold the next dose of vancomycin.
okay.
So the reason why they have this here for you is remember, gentamicins, your mycin, your vancomycin, they're very toxic because they're they're the super anti-infectives. That's why you have to watch the level also, because you don't want them to be higher than what they needed to be, because they can become toxic to your body. It's only the mycin. So you see gentamicin,
Yeah.
vancomycin, and tobramycin. So anything that is higher than that at its peak, do not give the dose. Hold the next dose. That is just what it means.
Okay.
So,
Yay.
yay, we are done. And you guys are ready, right?
Hopefully.
And you feel good. You feel good. You're all good. So, yeah.
Thank you.
You're welcome. So on Monday, I will post the names, and those that have not, I will just assign you your time. And Charles, you guys are going to be in the morning on Friday at 9 a.m.
Wait, is it Is it this Friday or
No, the
Friday?
next one. What is Friday after the 8th? Uh,
12.
the 12th, Charles the 12th. And guys, it's weather permitting, okay? If there's 10 inches of snow, we're not gonna test.
About 3 inches. We just call it off.
Inches.
Because I
If we don't
think
get
it's gonna
Any
snow
snowfall,
on
let's just cancel it, Miss Stephanie. Forget.
no,